The 12% rule is perhaps the most critical number to remember when diagnosing asthma because it separates a lifelong condition from a transient respiratory infection. In the world of board reviews, that 12% improvement in FEV1 after using a bronchodilator isn't just a statistic, it's the clinical marker for reversibility. Today, we're dissecting the core principles of respiratory medicine, from the nocturnal coughs of an asthmatic to the silent chest that signals a life-threatening emergency.
It's a huge topic because respiratory issues are often the first thing a patient presents with, whether it's a nagging cough or sudden shortness of breath. When we look at the Global Initiative for Asthma, or GINA 2024 guidelines, they really emphasize that while symptoms like wheezing and dyspnea are classic, they're notoriously non-specific. That's why that spirometry result you mentioned is the gold standard for confirmation. If you see that 12% or 200 milliliter increase in the forced expiratory volume in 1 second after albuterol, you've confirmed that the airway obstruction is reversible, which is the hallmark of asthma.
But what about the patients who present with these symptoms only at night? The board review material highlights that night cough and wheezing specifically point toward asthma. Why is the timing so consistent? Is it just the reclining position, or is there a deeper physiological rhythm at play?
It's a mix of both, but circadian rhythms are a major factor. Our airway caliber actually narrows naturally in the early morning hours, usually around 4 a.m. due to a dip in endogenous cortisol and an increase in vagal tone. For a healthy person, it's unnoticeable. For someone with hyper-responsive airways, that dip triggers a full-blown symptomatic episode. It's why we call it the morning dip. If a patient is waking up because they're coughing, you have to consider that their asthma isn't just present, it's likely undercontrolled.
And that leads us to the distinction between rescue and controller meds. The board notes are very clear. Albuterol is for rescue, and inhaled corticosteroids, or ICS, are for control. Yet we see so many patients using their blue rescue inhaler every single day. If they're reaching for that albuterol daily, we've moved past occasional and into persistent territory, right?
Exactly. Frequent albuterol use is a major red flag. According to GINA, using a short-acting beta agonist more than 2 days a week for symptom relief, not counting pre-exercise use, is a sign of poor control. It means the underlying inflammation isn't being addressed. That's where the inhaled corticosteroid comes in. It's the most effective way to reduce the airway swelling and prevent the exacerbations that land people in the ER.
Speaking of the ER, there's a specific physical finding mentioned in the board prep that feels counterintuitive. We're taught to listen for wheezing, but the silent chest is described as an ominous, potentially fatal sign. It feels like a paradox. If the wheezing stops, isn't the patient getting better?
That's a dangerous assumption to make in a clinical setting. Wheezing requires air movement. If the airways are so constricted or plugged with mucus that air isn't moving at all, the wheezing stops because the engine has essentially stalled. Recent case reports, including one published in the Journal of International Medical Research in 2020, describe fatal asthma cases where a silent chest lasted for hours. It's a sign of impending respiratory failure. You'd see a patient who's exhausted, maybe unable to speak in full sentences, and their chest is moving, but you hear nothing through the stethoscope. It's a medical emergency that requires immediate aggressive intervention, often involving systemic steroids and potentially mechanical ventilation.
Now let's pivot to the other side of the obstructive lung disease coin, COPD. While asthma is reversible, COPD is defined by obstruction that stays. The board notes link COPD heavily to tabaquismo, or smoking, which accounts for over 80% of cases. But I want to dig into the classic phenotypes, the pink puffer and the blue bloater. They're almost like caricatures of the disease.
They are, though in reality, most patients have a bit of both. The pink puffer refers to the emphysema-predominant patient. These individuals are typically thin because they're burning so many calories just trying to breathe. They have that barrel chest because their lungs are hyperinflated. You can actually see this on a chest X-ray as flattened diaphragms and increased retrosternal airspace. They're pink because they're hyperventilating to keep their oxygen levels up. The blue bloater, or the chronic bronchitis type, is defined clinically, a productive cough for at least 3 months over 2 consecutive years. They often have more cyanosis and peripheral edema, hence the blue and bloater labels.
It's interesting that the board notes mention the fear of removing the respiratory drive with oxygen in COPD is often exaggerated. For a long time, there was this dogma that you couldn't give too much oxygen to a COPD patient because they'd stop breathing. Is that still the consensus?
The thinking has shifted toward a more balanced approach. While it's true that high-flow oxygen can worsen hypercapnia, higher CO2 levels in some COPD patients due to the Haldane effect and ventilation perfusion mismatch, the board tip hits the nail on the head. Hypoxia kills faster than hypercapnia. You want to titrate oxygen to a target saturation of around 88% to 92%. You don't withhold life-saving oxygen out of a theoretical fear of suppressing their drive to breathe, but you don't over-oxygenate them either.
Moving into infectious territory, pneumonia is a staple of these exams. Streptococcus pneumoniae remains the most common cause of community-acquired pneumonia. But what about the walking pneumonia we hear so much about? The mycoplasma pneumoniae?
Mycoplasma is the classic atypical pneumonia. It's common in younger adults and often presents with a dry cough and a chest X-ray that looks far worse than the patient feels. That's why they're walking. In contrast, strep pneumo usually gives you that classic lobar consolidation, high fever, and productive cough. When you listen to their chest, you're looking for crackles or rales, which indicate fluid in the alveoli. If those breath sounds are absent or diminished instead, you might be looking at a pleural effusion, where fluid is actually separating the lung from the chest wall.
And we can't talk about chest pain without mentioning the pleuritic kind. The board notes define it as pain that worsens with a deep breath. It's that sharp, stabbing sensation. If you combine that pleuritic pain with sudden shortness of breath in a post-op patient, the red flags for a pulmonary embolism are practically screaming.
Absolutely. A PE is the great masquerader, but tachycardia is actually the most common vital sign abnormality you'll see. If you have a patient who just had surgery and is now suddenly breathless and tachycardic, you have to rule out a PE immediately. The gold standard for a stable patient is the CT angiogram. It's all about the Virchow's triad: stasis from being in a hospital bed, hypercoagulability from the surgery itself, and potential vascular injury.
There's also a section in the review on tuberculosis, which still carries its classic triad: weight loss, night sweats, and hemoptysis. It notes that TB climbs to the top, meaning it prefers the apical segments of the lungs. Why the top? Does the bacteria just like the view?
It's actually about oxygen tension. Mycobacterium tuberculosis is an obligate aerobe, meaning it needs oxygen to survive and thrive. The apices of the lungs have the highest ventilation to perfusion ratio, which translates to a higher concentration of oxygen. It's the perfect environment for them. That's why you see those cavitary lesions in the upper lobes on an X-ray in reactivated TB. And a quick board tip: a positive PPD test only tells you there's been exposure. You need a chest X-ray to determine if there's active disease.
We should also touch on lung cancer, specifically the paraneoplastic syndromes. The board notes mention that small cell lung cancer is frequently associated with SIADH. This is fascinating because it means a lung tumor is actually interfering with the body's water and salt balance.
It's one of the most classic high-yield associations. Small cell lung cancer is neuroendocrine in origin, so it can ectopically produce hormones like antidiuretic hormone, or ADH. This leads to SIADH, syndrome of inappropriate antidiuretic hormone, where the body retains too much water, diluting the sodium in the blood. Patients might show up confused or even having seizures because of hyponatremia. And then there's the Pancoast tumor, which sits at the very top of the lung. It can compress the sympathetic chain and cause Horner's syndrome, the classic triad of ptosis, meiosis, and anhidrosis on one side of the face. It's a great example of how a lung issue can manifest in ways that have nothing to do with breathing.
Finally, let's talk about sleep apnea. The board material points to obesity as the primary risk factor and daytime sleepiness as the hallmark symptom. It seems like a straightforward diagnosis, but the treatment, CPAP, is often a tough sell for patients.
It can be, but the data on its effectiveness is becoming even more compelling. Recent studies, including a large French database analysis presented at the European Respiratory Society Congress, suggest that consistent PAP therapy can significantly increase survival rates by as much as 39% in some cohorts, compared to those who don't use it. It's not just about stopping the snoring, it's about reducing the strain on the heart and preventing the long-term cardiovascular consequences of repeated hypoxia throughout the night. A polysomnography, or sleep study, is still the definitive way to diagnose it, and CPAP remains the gold standard for management.
It's remarkable how many of these respiratory conditions hinge on these specific patterns. The 12% rule for asthma, the 3-month 2-year rule for chronic bronchitis, and the apical preference for TB. These aren't just arbitrary rules, they're the distillation of how these diseases actually behave in the body.
Exactly. Whether it's the silent chest of an asthmatic or the paraneoplastic syndrome of a lung cancer patient, the body is always giving us clues. The key for any clinician or anyone preparing for boards is knowing which signs are the red flags and which ones are the diagnostic keys that unlock the right treatment path.
From the mechanics of a rescue inhaler to the life-saving potential of a CPAP machine, understanding these respiratory basics is the first step in managing some of the most common and critical conditions in medicine. If you found this breakdown of respiratory board essentials helpful, consider sharing it with a colleague or a fellow student who's prepping for their exams.